It is my pleasure to introduce Dr. Anat Stemmer-Rachamimov today. She's a neuropathologist in Massachusetts General Hospital and associate professor in Harvard Medical School. Dr. Stemmer-Rachamimov graduated medical school in Milano, Italy, and did her clinical training in Israel, internship, Canada, and the USA for anatomic pathology and neuropathology. She's the director of the Dana-Farber Harvard Cancer Center Special Histology Core in MGH, and the co-director of the MGH Neuro-Oncology Tissue Bank. Her clinical expertise and research interests are in CNS tumors and hereditary tumor syndromes, in particular in the neurofibromatosis, NF1, NF2, schwannomatosis. Her research laboratory is supported by grants from the NIH, DOD, and NF-related foundations, including NATP and CTF. Dr. Stemmer-Rachamimov has a long history in NF research and has numerous collaborations with NF clinical and research teams in the USA and elsewhere, and has organized or participated in numerous consensus conferences in which she often represents the only NF pathology expert. She's an expert in the interpretation and analysis of neurofibromatosis-associated tumors in patients with NF, for which she has an active consult service, and also of animal model genetically engineered mice and pigs for NF. Anat has over 180 publications, many in the neurofibromatosis field. She's a wonderful neighbor in my department, and we're happy to welcome her today. So you can go ahead and share your slides now and get started.
Okay. So thank you for the introduction, and thank you for the opportunity to speak at the AANP teaching rounds. And I will be speaking about a topic that is very dear to my heart, which is the peripheral nerve sheath tumors in neurofibromatosis. So I have no financial relations to disclose, and the aims of the learning objectives of this session is to explain the role of neuropathology in the diagnosis of NF patients, to review the appropriate diagnostic workup for the hybrid morphology tumors, and to apply the appropriate diagnostic workup for neurofibromas with atypical features. So we'll start with review of the neurofibromatosis. So these are three distinct disorders, NF1, which is also called von Recklinghausen and peripheral NF, NF2, which is also called Wishart syndrome and central NF, and schwannomatosis. And of course, now we have new nomenclature that I will go over shortly. So they all have new names now. These are genetically determined disorders that are characterized by peripheral nerve sheath tumors, and they're distinguished from each other by the type of nerve sheath tumor that is associated with them, and by other tumor types, and also by non-tumor manifestations. So this is just a short historical timeline. The first descriptions of NF1 and NF2 go back to the 1700s, although in some of the reports there is confusion between the two forms. There is the first diagnostic criteria were formulated in 1987 in an NIH consensus, and the two were somewhat teased apart. This was greatly helped by the discovery of the two genes, the NF1 and the NF2 gene, in the 1990s. And the next big step was the distinction of schwannomatosis as a separate syndrome, because it was very often mixed together with the NF2 syndrome. And then followed the discovery of the schwannomatosis genes in the 2000 in SMARCB1 and LZTR1. And we are now in a new era. There was a new diagnostic criteria were formulated, a new nomenclature for NF1, NF2, and schwannomatosis in 2021 and 2022. So multiple peripheral nerve sheath tumor imply that the patient has neurofibromatosis, but which type? So the NF1 is associated with neurofibromas, as one would imagine, and the syndromes that are associated with multiple schwannomas are NF2 and schwannomatosis. The new nomenclature that was proposed in 2022, the paper just came out, is that the tumors that are associated with multiple schwannomas will be called schwannomatosis. And the distinction will be of schwannomatosis that are related, that NF2 related schwannomatosis would replace the term NF2. Non-NF2 schwannomatosis, meaning what was used to call schwannomatosis, would be subclassified based on the gene that are involved to SMARCB1 related schwannomatosis, LZTR1 related schwannomatosis, and those that the gene is not known, the 22q LOH related schwannomatosis. So NF1 is the most common form, and it is about 1 to 3,000 patients. It's autosomal dominant, and the responsible gene is the NF1 gene, which is a RAS that encodes neurofibromin, a RAS GTPase activating protein. It's important to know, though, that half of the patients that have NF1 have a sporadic mutation, meaning that they're founders. They don't have a parent that has NF1. The hallmark is, of course, the neurofibromas, and we distinguish between two important biologically different neurofibromas, the dermal neurofibroma, which are postnatal and are, we think, hormonal responsive because they are increased in puberty and pregnancy, although there is some debate in the NF community about that. And you can see that sometimes they are in very large numbers, almost like a carpet on the skin of NF1 patients. They do not become malignant, but the burden of the visual and can cause a lot of distress to the patients. The plexiform neurofibromas are congenital, and they may be associated with soft tissue overgrowth. And you can see here an example. They are intraneural, and they grow from within the nerve, expanding it and replacing it. They're called plexiform because the gross appearance is that of a rope as the whole nerve gets expanded and replaced. And they do carry a risk of malignancy into transforming into an MPNST. So NF1 patients also have other tumors. They have gliomas, pilocytic astrocytomas, optic-gliomas, diffuse gliomas. They also have other malignancies, which include MPNST, sarcomas, leukemias, GISTs, breast cancer, a lot of different types. So other non-tumor manifestations that are also important for the diagnosis of the syndrome are cutaneous manifestations. These are particularly important because they appear in young age in children, and they include café au lait patches and freckling. Also, the ocular manifestations can be early, and these are the Lisch nodules that you can see up here. These are melanocytic iris hamartomas, or choroidal plaques, which are proliferation of dendritic melanocytes in the choroid. There are also characteristic skeletal dysplasias, cognitive impairment, and fibromuscular dysplasia of the renal artery, which can often lead to hypertension. The revised diagnosis of NF1 is what happened here is that the molecular criteria have been integrated into the diagnosis. It used to be clinical only, and now germline pathogenic NF1 variant in normal tissue, meaning germline mutations, are part of the criteria. In a patient that does not have an affected parent, this is not enough for diagnosis. You need to have one of the other clinical criteria. And I highlighted the role of the neuropathologist, which is basically in making the diagnosis of a neurofibroma or a plexiform neurofibroma. The challenges in diagnosis of NF1 is that there is overlap with other RASopathies, specifically the Legius syndrome, which is caused by this mutation in SPRED1, and it shares the same cutaneous manifestations as NF1, but none of the other features. Also, about 30% of the patients have only a subpopulation of cells is affected by the germline mutation. They are mosaics. So they have atypical presentations or segmental presentations and can be more difficult to diagnose. It's also difficult to diagnose the patients that are in early on because the symptoms take a while. They're time sensitive. So it's most difficult to diagnose them in children when they did not yet appear here. There are also specific types of NF that are challenging. For example, the spinal form, in which the only alteration is the presence of, the only pathology is the presence of multiple plexiform neurofibromas that affect bilaterally the spinal roots. So they can easily be, they overlap with the presentations of NF2 or schwannomatosis. NF2 is more rare. It's 1 in 25,000 patients, individuals. It's also autosomal dominant. And again, 50% of the patients are de novo mutations. They're founders with no affected parent. The causative gene here is NF2, and it's a shorter gene. It's only 17 exons, and we do have a hotspot. So in that sense, it's easier to screen. The encoded protein is Merlin, which is a scaffold protein, and the role, we think, is that of regulating the interaction of multiple intercellular signaling pathways. The tumors that are characteristic of NF2 are schwannomas, and they can affect cranial nerves, spinal nerves, and peripheral nerves. Meningiomas, which are very common. In fact, the risk of developing a meningioma for an NF2 patient over his lifetime is 80%. The meningiomas are often multiple, and you can see here there is a aura of NF2 patient that was removed during autopsy, and you can see that it's basically studded with multiple discrete tumors that each one represents a different meningioma. Also, they can present in the pediatric age group, and in a patient that is young that has a meningioma, one should think about NF2. Finally, they can have ependymomas, which are spinal. Although these are usually benign, the meningiomas may become atypical and even malignant, especially if you radiate them. But usually, most tumors in NF2 are benign. They're associated with a lot of morbidity and mortality because of the location of where they are. So you can have brainstem compression because of cranial nerves that are involved by schwannomas, loss of vision because of compression of the optic nerve because of meningioma, and paraplegia because of spinal tumors. The non-tumor manifestations in NF2, again, like in NF1, there are some typical ocular features. NF2 patients also can have neuropathies. That can be because of compression of peripheral nerves by tumors, schwannomas or meningiomas, but also there is a neuropathy that is specific to NF2, which is caused by sort of proliferation of Schwann cells that do not form a proper tumor, but sort of like loose onion ring formations. And then meningoendomatosis can be associated with NF2, and you can see here, this is a picture of meningoendomatosis with the proliferating meningothelial cells around vessels and intervening normal brain parenchyma between them. Glial microhomatomas are pathognomic of NF2. They're completely asymptomatic, and we find them as incidental findings in autopsy. And just as a side comment, 2% of the patients have Café spots, which of course can confuse clinicians when they try to sort the syndromes out. So the most common involved cranial nerve in the formation of schwannomas is, of course, the vestibular nerve, and the hallmark of NF2 is bilateral vestibular schwannomas. Schwannomas can also have a plexiform growth pattern, meaning that they grow inside the nerve and expand it and replace it. And these are usually cutaneous. Cutaneous plexiform schwannomas are very common in NF2. 30% of the tumors of schwannomas in NF2 have a hybrid schwannoma neurofibroma histology, which we will discuss soon. And then sometimes you can have a whole sort of like a string of pearls, a whole string of tumors along a nerve, and each one of them is a separate tumor. This is the characteristic histological feature of an NF2 schwannoma, in which you can see multiple separate lobules or nodules that are discrete. And in a study that was done in 2015, each one was dissected separately and analyzed separately, and they were found to harbor distinct and different NF2 somatic mutations. So at least in some cases, these are actually not a tumor, but a collision tumor, meaning that each one of these nodules is a separate tumor, and they just all sort of form a single mass. And this has clinical implications. You can see here a section from the inner ear of an NF2 patient that underwent autopsy. And we can appreciate that there's multiple discrete tumors that are involving the inner ear. And that can explain why when NF2 patients undergo resection of a vestibular schwannoma, the surgical outcome is often not as good as one would have expected based on what the surgical excision results are in the non-NF2 or, quote unquote, normal people. So this is a picture of a plexiform schwannoma, which is cutaneous, and one can appreciate how the nerve gets expanded and replaced by tumor. So the diagnostic criteria for NF2 have also been changed. And again, one of the most important changes is the inclusion of molecular criteria as part of the criteria. Again, it's important to note that the finding of a pathogenic variant of NF2 in a patient is not enough to make the diagnosis. There is the need to have a confirmed, pathologically confirmed schwannoma or another tumor type that is classic for NF2. And when everything is perfect, the detection of a pathogenic variant of germline mutation in NF2 is very high, 96. But that implies using multiple molecular methods. It also implies that the patient has a parent that has NF2, and the patient is a classic NF2 patient, meaning that he qualifies also by clinical criteria. When all these premises are not there, the detection rate is actually a lot less, and it can drop from 96 to 60% or to 70%. And one of the reasons that can happen is because, again, NF2 also has very commonly has mosaic forms in which only a subset of cells are affected by the germline mutation. And that can mean that manifestations may be segmental or that some clinical features are missing. There is some overlap between NF1 and NF2. And a lot of confusion can be caused by misdiagnosing the tumors with hybrid morphology. And there's a lot of overlap between NF2 and schwannomatosis, as both have meningiomas and schwannomas. And it's just a question of distribution and the underlying gene. So the last one is schwannomatosis, and the schwannomatosis, which now is divided differently, and I should say the non-NF2 related schwannomatosis, is also rare. It's about 1 to 40 to 70,000 people is affected. Only 15% are familial. The majority of the schwannomatosis patients are sporadic with no family history. And the syndrome is characterized by the disposition to develop multiple peripheral schwannomas and not vestibular schwannomas in most cases. And in some cases, but here it's a lot less common than in NF2, also meningiomas. The segmental forms are very common, and it's not really clear why, if that's a mosaic issue or a modifier issue. The one feature that sets schwannomatosis apart is that pain is very often a very debilitating symptom, and it's associated with the tumors, with schwannomas. So clinically, there is some overlap with NF2. The schwannomas affect peripheral nerves and spinal nerves, but vestibular schwannomas, unilateral vestibular schwannomas, can happen with, especially with LZTR1 related schwannomatosis. And the schwannomatosis are usually discrete, although there are some cases in which they can be plexiform. Importantly, there have been reports of malignant transformation to MPNST in schwannomas in patients with schwannomatosis. And the hybrid histology in schwannomatosis is very common. It's about 70% of the tumors. So the schwannomatosis gene story is a little bit more complex. The first and most important thing is that NF2 germline has to be ruled out. And because there have been cases in the literature and in clinical practice in which patients have been diagnosed with schwannomatosis and later have developed like full-blown NF2 or had a child that developed NF2. So clearly that was a misdiagnosis. There are two known schwannomatosis genes, the SMARCB1, which is involved in 48 or almost 50% of the familial forms and 10% of the sporadic forms, and it's in 22q. It's a component of the chromatin remodeling complex, and we know of it, like we're familiar with it from ATRT and the rhabdoid familial syndrome. And the LZTR1, which affects almost 40% of the familial forms and 30% of the sporadics, and also resides on 22q. And this is it interacts with the ubiquitin ligase complex, and it is altered in some glioblastomas. So that leaves about 15% of the familial forms and 60% of the sporadic forms with an unknown underlying gene. And there is an assumption that there are more genes that we just have not found yet. So the schwannomatosis story is a little bit more complex because other than the fact that we have multiple genes involved, we also have a 4-hit hypothesis. So the classic Knudsen hypothesis is that you have a germline mutation and then follows the second allele loss by a somatic mutation, and that forms the tumor. In the schwannomatosis tumors, we have 4 hits. So the first hit is the germline mutation in the schwannomatosis gene. The second and third hit is when one has the loss of the LOH of 22q with loss of the second schwannomatosis gene and a loss of one of the NF2 alleles, and then follows the fourth hit in which the second NF2 allele is lost. So the NF2 gene is involved by somatic mutations and LOH in the schwannomatosis tumors, but it is not a germline mutation, and this is why it's important to rule it out. The risk of transmission is 50% if the germline mutation is identified, which implies that it's an autosomal dominant syndrome. So the diagnostic criteria for schwannomatosis have also been revised, and again, this is an integrated diagnosis in which there is a rule also for the molecular analysis of the germline mutation. And basically, again, the role of the pathologist is to verify the presence of a pathologically confirmed schwannoma or hybrid peripheral nerve sheath tumor because they are essential for the diagnosis. So our first case brings up exactly that question, schwannoma or neurofibroma. And the patient I'm going to introduce to you is a 64-year-old woman. She presented with progressive enlargement of a mass in the left foot, and she has skin freckling of the right torso. There are no other dermal lesions. There's no family history of any type of NF. And she has 2 tumors that were excised, and both carry the diagnosis of schwannomas. So unfortunately, I cannot show you the slide, but you can look at it. But the clinical considerations of the question here is that the patient has peripheral nerve sheath tumors and therefore has some form of NF. However, her clinical presentation is confusing because she has the cutaneous manifestations of NF1, but the diagnosis of multiple schwannomas, which would place her as schwannomatosis or NF2. So the H&E slide that I have included shows a multilobular tumor, and there are areas that are cellular proliferations that are clearly showing spindle cells. In some cases, those spindle cells form nicely recognizable Verroque bodies. So one would suspect that this is in fact Schwann cell proliferations. And one looking at the multilobular appearance, one would think, could this be an F2? And if you do an S100 stain, which is also a slide that I have enclosed, one can see that those nodular proliferations are in fact S100 positive. So the question before us is the schwannoma versus neurofibroma. and it's important for the management of the patient, for the risk of the offsprings, and for the risk of delivering, of having malignancies. So the question that really one wants to know is, are there other cell types in this tumor that are not S100 positive, meaning other non-Schwann cells in the tumor? And between those S100 positive nodules, there are SMA positive cells that you can see here. So these are myofibroblasts, and numerous GLUT1 positive cells, which are perineural cells. So we have a mixed population of tumor cells. We have Schwann cells that are S100 and SOX10 positive. Fibroblasts or myofibroblasts, we can use CD34 and SMA to recognize those, and perineural cells, which one can show with GLUT1, Claudin, or EMA. So in summary, this is a case of a peripheral nerve sheath tumors with areas of Schwann cell proliferations, but it has a mixed cell population. It's composed of Schwann cells, myofibroblasts, and perineural-like cells. So the diagnosis here is a neurofibroma with hybrid features, and the patient, in fact, has NF1. So what are these hybrid nerve sheath tumors? The WHO definition is that these are benign peripheral nerve sheath tumors with combined features of more than one conventional type, so schwannoma, neurofibroma, or perineurioma. From a conceptual point of view, one can offer three different explanations as to what they are. They could be collision tumors, meaning schwannoma and neurofibroma that just happen to be next to each other. They could be a distinct biological entity that has another feature that we have not yet discovered, maybe a clonal alteration of a conventional tumor, or it can just be a phenotype of schwannoma or neurofibroma. So they can be difficult to classify, and we recognize three different types depending on the components. So the neurofibroma perineurioma are rare, and they are most commonly associated with NF1 and are thought to be perineural differentiation in a plexiform neurofibroma. There have been some cases of malignant transformation, but it's rare. And So the schwannoma perineurioma are sporadic. They're not associated with NF. They occur in young adults and usually are in the digits. And they have, the histology of classic schwannoma and perineurioma. And interestingly, a recent study showed that they often harbor VGLL3 rearrangements, and that sort of supports the biological entity hypothesis. And finally, as in our case, the cases of the hybrid schwannoma neurofibroma, again, we have two components, and they may be difficult to classify, and the options of how to sign them out can be depending on whether you do manage to classify them as schwannoma with hybrid features, which are usually myxoid schwannomas, or neurofibroma with hybrid features, in which case they're usually Schwann cell rich neurofibromas. Or if you can't tell and it's really you're not sure, then neurofibroma schwannoma hybrid tumor, which would just imply exactly that, but at least you're not calling it something that then turns out to be wrong. So the importance of saying schwannoma with hybrid features or neurofibroma with hybrid features is that it flags this tumor as being possibly associated with NF. This is an example of a schwannoma with hybrid features. So this is the myxoid part, and you can see that this can mimic the carrot shavings or the myxoid appearance of neurofibroma. However, S100 is really helpful because it shows that a lot of these pink carrot shaving-like things are actually Schwann cell processes. So diffuse S100 stain in the myxoid areas is the diagnostic clue here. So there's a couple of studies that are about hybrid tumors, and the one that is sort of a landmark one is the 2012, in which it was shown that most of the hybrid tumors are associated with NF, 60% of the series, in fact. And in that particular series, most of them were from NF2 patients. And the rate of NF2 the hybrid tumors in NF2 is about 30%. Other studies showed that 70% of tumors in schwannomatosis are hybrid, so it's a very common feature, and that is why it's important to recognize and to flag these cases. So about the type, like what that biological part about it is, there's a study that sort of ruled out the collision tumor hypothesis. The two different parts of the tumors were dissected and analyzed separately, and it was shown that schwannomas, neurofibromas are not hybrid tumors. There is a report about a ERB2 mutation that was found in a subset of sporadic schwannomatosis schwannomas that had hybrid morphology, but this was a very small subset, and it was not validated or shown in by other studies. And finally, the methylation study classification study by the Heidelberg group looked at a huge number, 170 big panel of peripheral nerve sheath tumors, and they included a small number of hybrids. But interestingly, the hybrids of schwannomas, neurofibromas clustered with one of the clusters of schwannomas, and it also so did the atypical neurofibromas. So their conclusion was that really what it shows is the composition of the tumor has a high percentage of Schwann cells. It doesn't really tell us beyond that. So from a practical point of view, the immunohistochemical workup that can aid in the pathological distinction of a tumor has a hybrid morphology. And it's important to flag these tumors and put the hybrid features in the diagnosis, even if we do know what it is. The second case deals with another question which is common in NF patients, which is benign versus malignant. And this is an NF1 patient who's 33 years old. He has history of multiple spine surgeries and that were benign, or plexiform tumors, and a mass in his thigh, which we can see here, which is a plexiform neurofibroma. And the slide, again, that I cannot show you, has a biphasic appearance. There is a part which is hypocellular, but has some really large, atypical, hyperchromatic nuclei that are worrisome. But because it's hypocellular and because there are no mitotic figures, one can assume that these could be degenerative changes and not worry about it too much. However, there's also a second area, which is hypercellular, in which all of the cells are these large atypical nuclei, and that would be very worrisome. So the most useful stain to do in that scenario, and I have included that in the slide there as well, is the Ki67. And the Ki67 is really helpful because it shows that there's really no proliferation in neither parts of the slide. Both the hypocellular and hypercellular parts are completely quiescent. There's no proliferating cells. So one can be somewhat reassured that this is not a malignancy yet. So the workup of a neurofibroma with atypical features includes markers to show the cell components, but most important are the S100 and SOX10, because one of the things that happens as a tumor progresses and becomes malignant is that they lose become differentiated and they lose their expression of S100 and SOX10. Proliferation, of course, is important, so Ki67 is helpful. And we have some molecular markers that can be helpful as well, in particular P16 or FISH for CDKN2A, as that is an early change and can signal the fact that this is not completely benign but atypical. And the H3K27 trimethylated loss of expression would imply malignancy or MPNST. So this is the S100 in the tumor that was enclosed, and you can see that S100 expression is retained both in the hypocellular and in the hypercellular area. And a mosaic pattern like we see here is okay. You don't have to have every single cell be positive because it is a neurofibroma, so they are mixed population. It is expected to have a mixed population. This is the SOX10, and again, as before, you can see that there's expression both in the hypocellular and hypercellular areas. The CD34 shows you the network of the fibroblasts in the tumor, and we can see that in the hypocellular area on the left right here, the network is maintained. This is the normal expression pattern of CD34 in neurofibromas. However, in the hypersensitive area, we have loss of CD34 positive cells, which is an atypical feature. P53 shows scattered cells, so indeterminate or wild type, at least not diagnostic for mutation. And this is the trimethylated H3K27, and there is retained expression. It's a mosaic pattern, but that is considered to be not diagnostic for malignancy. So the diagnosis here is of an ANUB or an atypical neurofibromatous neoplasm of uncertain biological potential. And that term was coined in an NIH consensus meeting in 2016. And there were two aims for that consensus meeting. One was to formulate criteria for the diagnosis of an ANUB, and the second was to replace the term atypical neurofibroma. So the transition from a plexiform to an MPNST is a multi-step transition, and it translates to a spectrum of pathological changes. And the ANUB is basically trying to capture one of those interim steps and define it as to exactly by defining by criteria. And if one wants to think about it conceptually, it's similar to the transition from of an epithelial lesion from a normal epithelium to dysplasia to carcinoma. And then the term neurofibroma, atypical neurofibroma, was dropped because it's confusing. It's confusing because it's used by different disciplines to mean different things. So radiologists mean atypical neurofibroma, a neurofibroma that has a nodule or an area that becomes PET avid or is growing rapidly. Clinicians mean atypical neurofibroma, a lesion that is growing rapidly or is becoming painful. Histologically, atypical neurofibroma can mean a whole bunch of things because there were no set criteria. So it could mean one atypical feature or almost malignant. So in NF1, the risk of developing MPNST is between 8 to 16%, depending on the different series. So it's significant. And it occurs in young people in their 30s and 40s, and the prognosis is bad. So it is important to recognize. The clinical concerning features are pain, rapid growth, and an MRI growing nodule, especially if it becomes PET avid. And you can see here that the transition from a plexiform over time, from a plexiform with one nodule that becomes enlarged and PET avid. So the spectrum of changes from neurofibroma to MPNST is basically one in which we have a neurofibroma that only has one atypical feature, and that can be cellular atypia, which one assumes is degenerative, or hypercellularity, which one assumes is a reactive process. Atypical neurofibroma with uncertain biological behavior, which is an ANUB, and that has two or more atypical features, but mitosis are not more than 2 per 10 high power field, and there's no loss of the trimethylated H3K27 and no necrosis. And then MPNST, which has all the features of atypical of an ANUB, plus more mitotic activity, necrosis, and loss of the trimethylated H3K27. He doesn't have to have all three. It's enough that it has one. So this is an example of a neurofibroma with one feature. So this is with only degenerative cytological atypia, and this is only with increased cellularity. And when one does the S100, there will be a lot of S100 positive cells, and the CD34 will be intact. And we can put it, if we put it on a table, you can put it here, and these are the features. And important to note that it would have very low mitotic count or none at all. This, on the other end of the spectrum, is an MPNST. It has a fascicular growth pattern. It's hypercellular, very atypical cells. It has loss of S100, loss of CD34, and importantly, it has a high Ki67, 3 or more mitosis. It may have necrosis, and it may have loss of expression of the trimethylated. And in the middle, we have our ANUB. So this ANUB is showing a fascicular growth pattern, and on the left, and some increased cellularity. There are atypical cells, but important to note, the mitotic count is low, Ki67 is low, and the trimethylated is preserved. There's no necrosis. And now we have added that CDKN2A homozygous deletion is another feature which would be defining ANUB. So the CDKN2A deletion has been shown to be a focal sort of a clonal change in a neurofibroma, as it was dissected out. One of those hypercellular areas with very atypical cells was dissected out and shown to be a homozygous deletion of CDKN2A in an otherwise heterozygous CDKN2A neurofibroma. And other changes, as I said before, are the 3-methylated H3K27 loss of expression. And multiple studies have shown that the ANUB actually behaves well clinically, meaning there's no recurrences and there's no metastasis, even when it's just resected without wide margins, meaning it does not have to be treated as aggressively as an MPNST. And that was shown in series in which it was correlated. The ANUBs were defined also by clinical features and by radiological features. So the bottom line is that the spectrum of changes from benign plexiform neurofibroma to MPNSTs is a spectrum with intermediate histology, and that is challenging to the pathologist. So having criteria is helpful. And the designation of ANUB implies that the biological behavior is uncertain, and they are worrisome and they should be watched, but they're not malignant yet. And it may be reflective of the biology, but sometimes, and one should always remember that, it could be a sampling issue. So in summary, NF-associated lesions can present challenges to the pathologist, whether it is the way to define them or the way to grade them. And the correct diagnosis has an important implication for clinical management and follow-up. And these, the criteria, both for the definition of the syndromes and for their lesions, are in continuous evolution as we acquire more tools to understand what's going on. And that is the end. Thank you. I'm just I'm open to questions if anyone has some.
Thank you so much, Anat. So at this time, we'll move on to the question and answer period. You can submit your questions via the chat box or also unmute to ask a question. When submitting a question via the chat box, please ensure that the message is to everyone so that the presenters and attendees are both able to see the question. To unmute, select the microphone in the lower left corner. And once you've asked your question, please remute to avoid background noise. So, Anat, I can read the questions that are coming in the chat. So first we have.
Sure, that would be nice. Yeah, thank you.
All right. So first we have Dr. Lopez. Thanks for the nice talk. Could you please tell us again, what is the best diagnosis for the hybrid tumors? And then continues the question, schwannoma with myxoid areas?
So that it's a good question, and the best way is to give the most information you have. Meaning, if you've done the stains and it looks like a schwannoma, meaning it's all S100, diffusely S100 positive, then it's very helpful for the clinician to know that this is a schwannoma. So you call it a schwannoma, but you add the word hybrid features in the diagnosis, meaning schwannoma with hybrid features should be the diagnosis, because that implies patient has a schwannoma, please consider NF, right? Same thing if the hybrid tumor has clear areas of Schwann cell proliferations, but other areas have mixed cell proliferations, then you think and you're pretty sure about it being a neurofibroma, then it's helpful to call it straight out neurofibroma and say with hybrid features. That would clue the clinician it may be NF1. If, however, you're unsure, and that happens because it varies and it seems like a schwannoma in one side and then in another one it's not, and you're not sure if it's a staining problem or a tumor issue and you can't tell, then the best thing is not to label it as a schwannoma or neurofibroma, but just call it a hybrid, because that doesn't tie the hands of the clinician. He can still make a clinical diagnosis of any one of those syndromes, and because you have not defined it as something that is contradictory, right? So it really has to do with how certain you are that you have managed to untangle it and you know that what it is.
Thank you. We have a few questions coming through. So the second one says, excellent talk. I recently had a case of vestibular schwannoma that recurred and progressed in size. How can I explain this? Is there atypical schwannoma or is it a hybrid tumor?
So it's not atypical. It sometimes happens. Sometimes it's because it's not a total resection. It's subtotal resection. So the part that was left behind grows back. And sometimes it just it recurs. It's uncommon, but it can recur. I wouldn't call it atypical unless you see, I wouldn't call it atypical at all because it's not a term that we use for schwannomas, but you can call it schwannoma with, increased proliferation rate if you think that it's high, or you can call it cellular schwannoma if it looks unusual. But otherwise, it's just clinically behaving more aggressively than expected, but it's not atypical in any other way.
Thank you. Next from Namita Sinha, great talk, Anat. Would you recommend CDKN2A/2B deletion studies for confirmation of ANUB, or do you make the diagnosis mostly on histology?
So I think that we make the diagnosis mostly on histology, but I think CDKN2A can be very helpful. So I think that in cases that you're not sure, I would do CDKN2A FISH or P16 immuno, and that would validate or make me feel better. If I see that it is present, it would be an ANUB. The presence of CDKN2A loss, I think, would be enough with just even one atypical feature to call it an ANUB. So you can use it as a diagnostic criteria as well.
All right, next we have from Mark Cohen. Can a patient be too old at presentation to be syndromic? Thanks for a great talk. And he also mentions that the doggies do not look Icelandic.
Yes. So I'll make sure that the next talk I give, I will put the Icelandic horse in the end. So no, a patient is not too old to have NF2, NF1, or schwannomatosis. They can have it at any age. And it has to do with if it's a mosaic, for example, or certain types of mutations can be very late in presentation. And with a schwannomatosis patient, I mean, usually the traditional time or the classic time of presentation is in the 40s. So, if you're a little late, you're already older. But even NF2, there are many cases of bilateral schwannomas presenting, very late in life, and they have NF2 affected children. So it can present at any age.
Next, Dr. Oviedo asks, do you teach these 3 separate tumor syndromes to year 2 medical students?
I think they should be aware, especially NF1 is a common disease, and I think, one should be aware. The hereditary tumor syndromes are also very valuable in understanding the pathogenesis of tumors in general, because it's a very clean model in which you know the beginning, the gene that starts the story, and you can show how it's involved both in neoplasia but also in normal development. So yes, I think it would be useful.
All right. Dr. Zhang says, thanks for the nice talk. In your slide of immunohistochemistry for H3K27ME3, it showed partial loss and partial retained. How do you interpret that? Is it positive?
So the mosaic pattern of partially positive and partial loss is basically considered to be normal, or considered to be not diagnostic for malignancy. So it is possible that some of the cells have already started to transform and you're seeing a subset of cells, but this is not supported by data that shows that mosaic tumors are more likely to progress. So from what we know from the data by the Hornick group and other studies that followed, mosaic expression of trimethylated is considered normal. It's considered the same as wild type.
Retain. Okay, then we have both Sandra Camelo Piragua and Areli Cuevas Ocampo have basically the same question, which is P16 a good surrogate for CDKN2A homozygous loss specifically in ANO?
So I think it is. It's not always as clearly as easy to interpret, because sometimes it's hard to tell. It's there's background, and is it real staining or not, etc. But it's particularly useful when you have a case that there is one focus, like we have in the slide that I submitted here, that there is one particular focus that you're concerned about. Because what you may see using P16 immunohistochemistry is that it's expressed everywhere and lost in that particular area. And that's very telling. And if you did the CDKN2A FISH, you may see the same thing, but if you do CDKN by dosage, you may not be able to see that.
That makes sense. And I think the last question is from Ivan Aldecoa, who says, thank you so much for the talk. Which could be the best clues for pigmented schwannoma versus melanocytoma?
Pigmented schwannoma versus melanocytoma. That's a whole different story. And it actually has nothing to do with NF. But I think I think melanocytomas are usually very heavily pigmented. They do not have Samoa bodies, which can be helpful. Pigmented schwannomas are considered to be a malignancy. They are now considered to be pigmented MPNSTs. So you would expect to have some signs that are worrisome, such as invasion into adjacent tissues, high proliferation rate, mitotic activity, etc. But it is a very difficult differentiation. One can be also helped by, mutation analysis. Molecular would be helpful here.
Great, that's all for questions, and everybody thanks you in the chat for your answers and for your teaching.
Well, thank you. Thank you for the opportunity to talk about this.
All right, thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your Path LMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Stemmer-Rachamimov for an excellent presentation. This concludes the session for today.
Thank you all.
Thank you again.